Welcome to the Resilient Performance Podcast. This is Keep It Real number 34. We're going to keep it real on some rehab protocol considerations.
Yes. So I have a client that I'm working with who's going to go in his freshman year of college basketball. He's coming off of a labral repair for an acute labral tear that happened last year that kind of played the whole season with. So he just saw his follow-up with his surgeon. I believe it was like his 4-month follow-up. And the surgeon told him that he can now start doing agility and jumping, but that the running progression does not start until another 4 weeks from now. So until basically 5 months or a little bit more. So I just want to talk about with you guys, like other protocols in general, and kind of you start this one from a specific standpoint. Because if we think about like how we understand the forces involved with running and what agility actually kind of entails, like there's a running component of agility, like to be able to change direction, you have to have been moving, which means you probably have to have been running beforehand. So the kind of the frustration that, you know, I think for us as PTs, when we get a protocol like that just kind of doesn't really make sense overall. And then how can we still follow the protocol and the precautions, if you will, of not trying to do running, if you will, right? But still trying to give the client what they need. So for like this example, it's like, I'm definitely going to start doing some change of direction work and start with some closed loop things and, you know, lower intensities, build up intensity, all the kind of normal progression of activities that I typically do with my field sport athletes. But I'm definitely going to start including, because he has to be able to run a little bit to change direction and do agility work, start introducing like, you know, more A runs and other low level running progressions without getting into like actual, you know, 20-yard sprints or flying 10s or things like that. So do you guys have any other experience with protocols like that, where like there's just this kind of order of activities that really does not make sense like this does?
Yeah, I mean, all the time. Go ahead, Greg.
I was just going to say, like, I don't know that, I think more with these throwers that I'm seeing, some of the protocols, I think it's more so just like the timeline doesn't make sense in my head, but it's not necessarily like in the wrong order, thankfully. So like like as in one, so we would say, the three of us, I think, would all agree, like that's the wrong order of operations for how you would want to progress somebody back to return to play. And for the throwers that I've worked with, like say after Tommy John surgery, I think it's more like the timeline of it. So like it might say, like wait till week 8 to start doing like external rotation strengthening of the shoulder after Tommy John surgery. But then like the kid's supposed to start throwing week 14. And like, that just doesn't make sense to me, where like that time frame doesn't make sense. And usually I have kids doing external rotation work like way earlier on, because there's no valgus forces at the elbow. So I don't know why people are afraid to do it very much. And then, like there needs to be just some space and some sort of buildup. And if you don't have enough time, that's another way that a protocol might not make sense, where again, we're like, okay, well, we don't want to like change this completely and completely flip things. We have plenty of experience working with these injuries, these surgeries. So like, we know what are good and bad, you know, like sort of responses to what we do with people. So we feel comfortable changing things a little bit, but like, how do we make it so that it's not completely different, or, you know, we're like spitting in the face of a surgeon or anything like that. That's more of the challenge. And like how having that conversation with the athlete and like finessing your way around changing a protocol gets a little bit tricky sometimes.
I think that's like the hard part, when we are put in that spot where we're really kind of like the primary person in charge of the rehab, which is really what we are when they see the surgeon for 15 minutes every 4 or 5 months, whatever the kind of follow-up is. It's like, how do we continue to respect them while giving the athlete what they need, even if the protocol that we are supposed to be following doesn't really kind of make sense?
Yeah, and in the case that you mentioned, Trevor, with somebody coming off a hip surgery, it actually makes more sense if you're trying to, like target certain tissue or keep stress off certain tissue. Like change of direction work is way more stressful on the areas that were impacted by that surgery. Like if you look at where that surgery occurs, like usually like there's some stuff that goes around like at the adductor and in the pubic insertion area, like running linearly would make a lot more sense if you're trying to reintroduce that type of stress, from a return to play standpoint than doing change of direction work. So I think this is one of those things where I understand why a surgeon to a degree would want to micromanage a protocol. I'm trying to like step outside of, like our lens, and you have to look at it like they have to assume that they're not always going to work with a competent rehab provider. So they have to cater to the lowest common denominator. It kind of reminds me of like in the military when somebody on the base got a DUI over the weekend, like everybody on Monday was getting DUI training, even if only 1 out of 2,000 people on the base got the DUI over the weekend. It's just like, that's how people do things, because once you give discretion, one person discretion, you've got to give everybody discretion. And then it's kind of hard to keep track of. And, the surgeon assumed the most risk because they went in there and operated, and they don't want, assuming they did a good job, to have that, compromised by somebody being overzealous in rehab. I think that, so I understand it comes down to discretion. I did an article about this, and I think it's in our subscription site, about how I think that guidelines from surgeons should be more about constraints, like what should you not be able to do versus what you should do and how you should do it. So it's like, if you want to tell me that you don't want somebody going past a certain range of motion in these weeks, and you don't want somebody running in these weeks, like that's fine. But beyond that, like, don't tell me how to develop the other stuff. Make it more about like via negativa, like don't do these things during these times and leave everything else up to me. And the things that you think are really dangerous and can compromise your surgery, like make them off the table, and I'll respect that. But when you're telling me like, here's how I want you to progress somebody to running, it's like, I think I can probably do, and we can do a better job, and our profession can do a better job of reintroducing running, assuming that like it's about the details, than somebody who doesn't do that every day and does surgery. So, the other thing is, a lot of it's about relationships. Like I can't speak for you guys as much, but I don't get probably as many post-op patients as you guys do, but the ones that I do get tend to come from surgeons that I have a very good personal relationship with. And they're the kind of people that like, they trust me, and they'll just be like, they'll tell me like 1 or 2 things that they care about, and everything else is up to me. But it's also interesting. It's like, if you're getting a referral, actually, if you're getting a patient that sees you direct access, even if it's post-op, like what is your responsibility to that surgeon? Because it wasn't a referral, like the patient or the athlete came to you voluntarily because they made the decision. Like how much, there's a certain amount of professional respect and courtesy that you should pay to that surgeon, even if you haven't met him or her. But like, are you obligated professionally to follow that protocol if you don't agree with it? So that's also an interesting question. Now, if it's a referral, then I think it's a little bit more delicate, because that person sent you a patient, they have certain expectations. And that's where, like, I think, again, there's some discretion and a little bit of, finesse that you have to introduce in that kind of situation. But it reminds me of like with knee surgeries, there are some surgeons who are like, I don't want anybody doing open chain, quad strengthening. And I think we all agree there's a place for that, especially when, you want to make sure there's no compensatory patterns and you're trying to isolate a quad. So maybe for those patients, I might have somebody do like, get on a leg extension and do something that's like isometric, or, through a very small range of motion, not the full range. So at that point, it becomes a matter of semantics. Like I know I have to assume that a patient is going to tell the surgeon everything that I did and didn't do. So if the surgeon asks that patient, hey, did you do leg extensions? And they say yes. If the surgeon calls me, I could say, oh, well, we didn't really do it through a full range of motion. I just had them, I set the pin, at whatever, 90 degrees of knee flexion. I had the athlete do an isometric. It wasn't really a leg extension, and they might be like, oh, that's okay. So again, if you're going to deviate from what the surgeon wants, you have to assume that it's going to be relayed back to the surgeon. And like, how are you going to finesse that and use semantics to your advantage while also being respectful of the surgeon? So there's a lot of things that go into it, and it can be a little bit messy.
Yeah, and I definitely think I'm thinking more about what you just said about whether the patient was referred to you by the surgeon or not. And I definitely am more likely to do what I think is appropriate. It's definitely happened in the past. I'm definitely more likely to make things what I want it to be if the patient found me themselves, or maybe I was working with them prior to the surgery and they're coming back. yeah, I mean, some of the surgeons like won't send athletes a throwing program. So I'm like, all right, well, I have one that I like to use all the time and it works really well. And I'm pretty confident because I've seen this surgery a billion times now. So we're going to use this. And every patient's like, yeah, I trust, I'm cool with that. I know you work with this all the time. So they're comfortable with it. But yeah, definitely more likely to mix things up.
No, I think that's a good point.
For
And
sure.
I mean, I think of like some of the surgeons, because we definitely see more post-op cases here in Jersey. And I think we do have like the doctors who kind of refer to us regularly. And then we have like the kind of randoms that somehow get into us, whether it is through our referral from the doctor or a friend who had the same surgery who we treated sends them to come and see us or whatever. But the doctors that we have the good relationships with who refer to us regularly, like their protocols are typically, I would say, like the best ones because they're kind of what you mentioned before, Doug, of like very generalized overall like structure type of things, not specific activities and necessarily like specific dates, like not until, like for example, the kind of case we're talking about is like not until whatever it would be like week like 16, 18 running starts. It's like, okay, he can definitely start running before if you kind of check the boxes, cross your T's, dot your I's in the early stages of your rehab. He could probably start running at 10 weeks, at 12 weeks, just significantly earlier if we have been allowed to like do activities to tolerance that don't have pain, that don't break the range of motion, precautions and things like that. And I'll say from the surgeons we have good relationships with, those are typically how their protocols are kind of based. And there's always such a good, if a patient comes in and something's kind of weird, like we can hit them up and ask them a question. And if they need to go in and see the surgeon real quick for a quick visit so they can get, their opinion on it as well. Like that's when I think like the whole rehab process just goes so much smoother, is when there's that communication and dialogue between us, and whether it's, I would say it's really like the surgeon himself, but it's a member of their team who's kind of in charge of their case, that makes such a big difference for us as PTs. And I think for the patient to have a better experience and get back to where they want to go quicker is when there's a general timeline, but like this is malleable, this is plastic, we can change this, depending on how things kind of go in general. Because I've had, kids who at 6 months post-op ACL look unbelievable and they've been cleared by the surgeon. I've had kids who are 6 months post-op ACL that don't look good yet, in my opinion, and their surgeon thinks that they can clear them. But there's a difference when I have the discussion with the doctors. I can give them a true opinion of like, look, this is how the last 2 months of our sessions have been, versus like this doctor who sees them for 15 minutes and clears somebody, but I don't have any sort of input from them to be able to kind of, for them to understand. But they're just like, yeah, most of my kids are fine at 6 months. So then they kind of clear them. So I just think like that communication piece in terms of setting the protocol and allowing the protocol to change is super, super important. So like we always, like the doctors we refer to are the doctors who we're all talking about, that we have relationships with, that we can text, that we can call, that we can get a patient into, that the patient can reach them whenever they need to, if they have questions that like we can't answer.
And I also, now that I'm thinking about it too, when like to keep it real too, if you have a patient coming to you from a surgeon you don't know yet, you almost like want to hit a home run. Like you want to do an even better job, because I mean, like it's human nature. You want people to think you're awesome at what you do.
Yeah.
And then like we own a business, so there is a financial motivation that we can't
To get
ignore.
results, yeah.
And we want people to refer to us. So that like we'd be lying if we didn't just even like touch on that. And if there's a surgeon that I haven't had referrals from, like I'm gonna do my best to like, again, knock it out of the park. And like hopefully they notice a difference, and just them noticing it, maybe that helps us help more people, helps our business. We can then reach more people. There's more than just the actual protocol itself that we're talking about.
Yeah, and I think if you're a surgeon, like you just don't want to get a call from a patient being like, I got hurt at PT.
Totally.
And that's why they micromanage stuff sometimes. But if you do, and that's the thing is, if you're going to deviate from what a surgeon wants, you better be confident that like you're doing the right thing. Because ultimately, like if you do a good job, even if you deviate, the surgeon's going to be happy.
Yeah.
Right. But again, like you don't want them getting that call like, oh, I was overzealous and I hurt my knee or whatever. And then you're never going to get a referral from that surgeon again, and you're blackballed, and deservedly so. So yeah, it's tricky, but I think that a lot of times like you just have to trust yourself, and there's a lot of discretion. But if you're going to deviate, you better be correct, because if you're not, then you're going to burn yourself.
One of the things I wanted to backtrack to was Greg's point earlier of like the timeline of things not making sense. Cause I think there's like two issues that we kind of see. It's like the case that kind of brought up with the hip, where it's like the order of activities like don't make sense. It's like strength and then change of direction and jumping and then running. It's like, okay, should we strength some sort of plyometric before we get into probably linear stuff and then more, lateral multi-directional speed and agility. And then there's like the timeline of things that don't kind of make sense, which I've seen as well, where it's like strength training and then, like say the orders of activities is good, but then it's like they get week 20 to 22 is when you can start doing like return to sport, agility, blah, blah, blah. And then it's like at week 23, they should be clear to go back to their sport, or like at 6 months, just say like that in general, like at 6 months, they should be fully good, but they are only allowed to do like high level stuff for like 3 to 4 weeks before that 6 month mark. And it's like, well, that doesn't really make any sense. I always like, and I would say I don't necessarily follow it, but I think that concept is really good. It's like with the throwers that Greg's worked with, it's like if they're off for 12 weeks, then they have a 12-week buildup before they get back to like full speed kind of, throwing stuff, so that their time off is followed by like that same amount of time being back on, building back up. So I think that kind of makes sense as well. It's like if you've been doing, say you got hurt and then a month later you had your surgery and then we're 3 months in the rehab process, okay, that's 4 months. We should probably say like in another 4 months, if now is the day we start, we should probably say in 4 months is more realistic for when you can get back on the field, if we have the appropriate time to be able to go through each of the type of reconditioning phases that we need to be able to get you back to your sport, versus it's like, oh cool, you've done, you had surgery 5 months ago and your range of motion's been good and blah, 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 but you've only done like really easy low level activities, but you're getting cleared at 6 months, but you only have a month now to actually try to get back into game shape. It's like, that is another big kind of red flag in my opinion, where, like Rob Panarello said, it's like, can you handle, like, do you meet the standard of the sport? So it's like, if you only have a month to train and say you're going to go play offensive line of football, it's like, and you haven't back squat, or not sort of back squat, but like done true strength work, right? It's like, well, then you're not going to be able to handle the sport. Like you're not meeting the strength requirements to be able to play the sport safely. So I think kind of looking at the whole length of time you've been off and how long does it really take you to, if you're just a healthy athlete going into an off season, how much time would I want to train you to be able to get back to your sport, to be able to compete at a high level, to be safe, to be able to protect yourself, and ultimately to like be able to function within the team, is really something that needs to be considered too when we're looking at the whole return to sport process.
Yeah, I've definitely had that before, where there was a shortstop, high school shortstop, had ACL surgery, did his rehab somewhere else, and then his surgeon sent him here. I think he wrote on the prescription like 4 weeks, one time a week, to do like agility work before baseball started.
Before getting cleared.
So he had 4 weeks. He hadn't done anything besides jogging, and he had 4 weeks to get back to sprinting, change of direction, agility for baseball in 1 month. And he was only supposed to go once a week. And it's just like, this doesn't make sense. And then like, I wound up hearing from the parent like a month into the season that the kid's tired and he's sore. It's like, well, yeah, I mean, like,
not in shape.
Not surprised. Like, I mean, he didn't look great, and he just needed more time and more work. And like, you can't train faster than you can adapt. It doesn't make sense.
And a lot of times it comes down to like your ability to talk your way out of things, and that's where the semantics comes in. If someone says like, I don't want the patient running, well, what does that even like really mean? Because they probably don't want the person going out for running a mile the first time they run, but it's like the running that we would do initially would be more technique-based, drill-based, tempo-based anyway. So it's like, oh yeah, like I didn't have him run. I just had him go for like 15 seconds on a curved treadmill as part of his warm-up for his agility training, even though like that is your running progression. Or if someone says, I don't want you to do any running until X weeks out, but you can do strength training. It's like, well, part of our like acceleration progression would be doing resisted accels, either band resisted, sled resisted. And because you're slowing the person down, it's actually safer. You could be like, well, we weren't actually like running. We were just doing like strength work, because it is strength work, right? Like, and you're not, I mean, it happens to be the proper progression anyway. It's safer. It is specific strength work. So yeah, but it's also running, but you could be like, well, no, we're not like, I don't think he's ready to run yet, but this is it's strength work that's a little bit more specific to running. It's like, oh, and so again, there's ways to finesse this stuff, but you just don't want to deviate too far where like you can't justify it at all.
Yeah, and then I've also had a case where I knew an athlete before they had a surgery, and their family is friendly with a surgeon who wound up doing the surgery. And they connected me with the surgeon. So it's almost like I already had like trust built with the surgeon who I'd never spoken to.
Yeah.
I spoke to him once on the phone, and it was like from right away off, like the conversation was like it was one of us, and he was just like, oh, like just just don't do this, but like you don't have to follow the protocol to a T, and like I trust you can kind of do what you think is best. So it's like I think in general, like if a surgeon just knows you and can have a conversation with you, they're gonna trust you way more.
Yeah.
But I do agree that like I don't blame them for kind of trying to hold the reins a little bit tighter, because they just don't know where you're going to wind up and what you're going to wind up doing. And everybody's heard horror stories about
For sure.
things being done inappropriately. So you can't fault the surgeon at the same time.
Here's a question for you guys. So if there was a surgeon that you didn't know and they said, whatever, like, I don't want you doing any open chain quad stuff, and you were probably going to do it anyway, would you confront the surgeon and be like, why don't you do open, and try to like change their mind and give them PubMed articles? Or would you just kind of discreetly do it and not say anything?
I would definitely like ask them why and see if they actually have kind of a rationale for it. And if the rationale is very easily disprovable, I think that's kind of a different conversation, right? If they're like, oh, it's forces and stuff that, you're like, well, that's actually like not how it works.
Sure.
That's kind of different, right? Versus I think there's certain people that just have like oh, it's bad, right? It's like, that's kind of those people I think are almost harder to kind of dissuade sometimes when their opinion on something is not really, it's based on like hearsay and kind of like myths, rather than like they have some sort of mechanical explanation that may be wrong. That kind of makes sense, right? Or it's like, well, I had an athlete one time who they hurt their knee doing a knee extension. It's like, okay, well, that's one time out of how many cases have you done this for?
And it wasn't with you.
Yeah, and it wasn't with me, blah, blah, blah. So I think that definitely would impact like what I would do. But I think I would still I think I would kind of take the route like you were talking about, Doug, like maybe we're not doing full open chain, a full arc, full range of motion knee extensions, but we're doing ISO parts of the range of motion wherever the athlete kind of needs it. Like, I think there's just so many kind of ways around, like we talk about, not necessarily breaking the rules, but bending the rule a little bit to still give the athlete what we know that they need, but still following the guidelines, if you will, of the protocol.
I probably wouldn't ask them why, to give you the other side of the story. I would probably not ask them why not to do something at that point, just because I don't know them enough yet. Like, I feel like I wouldn't have a good conversation with them unless they like already have a little bit of trust with you. I'd first rather find a way around it. And like, there's plenty of other ways you can load the quad. It's like, is it the end of the world if we don't do it? Probably not. However, I'd probably ask the patient, like, when is your follow-up? And try and focus my efforts on their follow-up being like out of this world, like you're doing like, I want you to continue progressing, do what you're doing, so that you already then have some sort of credibility with the surgeon you don't know. So then it's like, all right, now that they've had a successful follow-up, they're doing way better than they should be, or they're doing great or whatever. Now the surgeon can trust us a little bit. Now we're going to start doing maybe a little bit of stuff that I would want to do that maybe isn't allowed, air quotes.
I think I lean more towards what you're saying, Greg, because I don't know if a surgeon wants a smart ass PT being like, oh, why don't you, well, you should do this because, and especially like if they haven't met you yet, then they're probably more likely to never send anybody to you again, because like people don't like getting their mind changed. I think that when to have that conversation probably would be if you did a really good job with a couple of people, and then the surgeon's like, hey, what are you doing with these people? And it's like, oh, and again, still respecting the constraints. Like if it's, I don't want any open chain quad work, it's like, well, maybe you don't do it isotonically through a full range of motion. Maybe you say we're doing active range of motion where I'm putting them in the most flexion they can tolerate within your parameters. And we're doing some isometric work for range of motion, even though it's really strength work and it's open chain, quad work. But yeah, I think that like people don't want to be told, they don't want their mind changed initially, but there probably is a window of opportunity to introduce that later on once you have their trust.
Yeah.
But that said, I think sometimes we have to give the surgeon the benefit of the doubt, and there could be reasons why they specify. So we could be like, well, this seems dumb, but there could be a reason for it. Like maybe it wasn't a run-of-the-mill ACL surgery. Maybe there was other stuff involved that we just got like the ACL protocol. So I think that probably the way to kind of make everybody happy and do the right thing by the patient is to, anytime you get a referral from like a surgeon that you don't know, is to even email or call the office and just say, hey, was there anything unique about this procedure that I need to know about? Or was it just a, patellar tendon graft ACL reconstruction? And it's like, oh yeah, we actually did this too. And that might be why there's this thing that doesn't seem to make sense. But if it wasn't a unique procedure with like, other anatomy that wasn't compromised, then that's when you can kind of be a little bit more clever and finesse things. So again, I see it from both sides, but I don't know if initially that would be when I want to say like, well, like obviously in a diplomatic way, like you're wrong. You should.
Yeah, I think like
chain quad strengthening
question is different than
Yeah.
trying to like
Yeah.
convince them why. But I think it's just like it's always helpful to
Yeah.
kind of know like, do they have a real reason why, or is it just some sort of
Yeah.
like, oh, it's bad. Like that's
Right.
bad. Tell her to do open chain. You're like, okay, whatever. Like
Because even if you
bad.
ask them why, if you ask them why and they're like, well, here's why. If you don't agree with it, then what are you going to say? Like,
Yeah, no, it's like, oh, okay.
yeah. Like you're probably not going to try to convince him that he's
No,
wrong.
definitely not. Yeah,
Yeah.
be diplomatic about it.
Yeah,
Yeah.
and then to continue talking about this, I have another situation with a local surgeon where I can't even remember how I met the surgeon. I think he was like more new to the area and wanted to meet some local therapists. So wound up meeting him. He just like walked into the clinic one day, and he had sent a baseball player who he had diagnosed that had glenohumeral internal rotation deficit, which I've written a blog about how I kind of don't really care about that diagnosis. So, and regardless of what the diagnosis is, like I still need to give these people what they need, their range of motion and everything. So after seeing the patient he sent me once, I sent a picture of his shoulder range of motion back to the surgeon. I texted it to him and he was like, what did you do? Because he just was like surprised that we could get a change like that. And it was, again, it's just like another situation where like, I want to hit a home run with this person from a new surgeon, make a good impression. And then they're asking me what I'm doing. Like you said, like they're going to ask, what did you do to get this change? And that just opens a can of worms then where there's just a dialogue about how I work versus what the traditional, what does PT school teach us? And, without doing a sleeper stretch for 8 weeks, like you can get internal rotation and everything back to normal within a half-hour session. Like it's very possible. So for him, it was like, wow, this is great. And then now he sends me people.
Yeah.
He only sends me baseball players at this point. I guess that's all I work with. But now I'm getting people from him regularly. And they're all non-surgical at this point, I believe. So for whatever reason, he found value in something I did.
I think that's like how we've always tried to like operate with our clients is like do a really good job. First and foremost, do a really, really, really good job. Give them a great experience, give them results that they are hopefully looking for. And it's like, then when people find out about it, like this example, it's like, just be a good person, talk to them nice, like don't try to act like we're better than everybody, just like be a part of the team, who's helping this athlete, whether it's their sport coach and a surgeon and a athletic trainer at school. Like it doesn't really matter who's kind of involved with it, but just always trying to always knowing our role, understanding what we have control of and what we can impact, and ultimately like trying to communicate effectively with whoever we're working with. I think it's like that's what makes a difference. I feel like a lot of this conversation today has been, it's like, how do we communicate more effectively, whether it's with the client, whether it's with the surgeon, or whether it's with somebody who doesn't refer to us regularly, somebody who does refer to us regularly. It's like, how do we kind of like always go do those things like the right way versus like oh, that's a stupid protocol. I'm gonna throw it in the trash. And like telling the patient, like, your surgeon's protocol is so dumb, and like being like negative about it. It's like, that doesn't do anything for anybody involved. Doesn't help us build good relationships. Doesn't give the patient confidence in their surgeon or in us, or it just doesn't, like, none of that comes across well. So it's like, how do we always do things the right way? It's like we were saying, it's like if we do things the right way, good things are going to happen from a care standpoint with our clients, and from how we build relationships, how word of mouth spreads, all that stuff.
Yeah, like
Just to clarify, I don't dislike the sleeper stretch.
We're gonna have another podcast about the sleeper stretch.
I just think it's overprescribed. I think most people typically don't need it, or they're doing it and they're actually making things potentially worse. But unrelated, I do give the sleeper stretch to people sometimes when it's appropriate. Not the scope of this conversation.
Yeah, I mean, we refer out to people too. Like, we refer to physicians, and like we have people that we trust. So we're not like, oh, hey, patient, like, tell your surgeon, like, this is the surgery that you want to have, or the kind of injection. Like, it's so much easier for everybody involved if you just trust someone. It's like, look, go to this orthopedist. Like, they're gonna get you what you need. Like, I'm not the one to tell you that. Or here, like, we're done with you at this point. Like, go to your strength coach, go to your trainer. We trust them. We might tell them, like, one or two things that we found insightful, and like, they'll do the rest. Like, it's actually exhausting to have to keep tabs on people and micromanage them. So looking at things in good faith, like, I don't think surgeons like want to have to do that. Like, in their ideal world too, they would just find people they trust and be like, yeah, here's like a couple of things you need to know, and go do your thing. Like, no one has time to like keep tabs on everybody. So I think it ultimately does come down to relationships. And even if you don't agree with what you've been prescribed from a protocol standpoint, like, try to navigate it delicately and don't deviate too much, because it is disrespectful to, like, it is kind of an FU to another professional if you totally ignore some of those marching orders. So you have to walk a tight line there, but I don't think anybody achieves anything by just bad mouthing another professional.
Yeah, not
Definitely. All right, I think that's enough of this.
That was good.
I think we beat that one up. That's pretty nice.
Sleeper stretch next time.
Yeah, I don't think that's enough to talk about, but
45-minute podcast on when to not use the sleeper stretch.
yeah, no thanks. But yeah, hopefully we see you guys on our membership platform. We've got new content coming out every month, and we look forward to keeping it real with you.
Thanks, everybody.
Sleep tight, sleeper stretch tight.
Thank you for listening to the Resilient Performance Podcast. For 10% off our continuing education membership platform, please use promo code PODCAST at our website, resilientperformance.com, and be sure to join our mailing list for monthly exclusive content.